So next we have none other than Dr. Mohan Rajan, sir. I'm sure all of us know Dr. Mohan Rajan, and if I have to start the introduction, then it may take 10 minutes. And so we are almost short of time. Sir is a teacher of teachers and an excellent cataract surgeon. He's done more than 1.5 lakh cataract surgeries, as well as VR and a whole bunch of other things. So in short of time, because we're short of time, I'll straight away hand over to sir.
Thank you very much, and good morning, ladies and gentlemen. Let me thank the KSOS for this wonderful opportunity. It's always a pleasure to come back to Kerala, and the love and affection and the warmth is something which is incredible. And I'm going to talk to you about the 3D, the Decentered, Dangling, and the Dislocated IOLs. Okay, and yeah, you are able to see my presentation. These are my financial interests. So, how many of you have had this problem of late? Especially after the COVID, I find that there's a huge number of dislocated, dangling IOLs. I don't know for what reason. We see this dangling IOLs, we see the decentered, we see this dislocated into the vitreous as well. So let's see how we manage this, different approaches. This is a 70-year-old male. I'll give you some case scenarios. Phaco-foldable 15 years back, 6'9" vision, and complaints of oscillopsia. Oscillopsia as if everything is moving, as if he has taken a couple of pegs of whiskey, okay, and history of blunt trauma, and there are pseudo-exfoliation. You can see how it is moving around in the eye. So this is, though he had 6'9" vision, he was not very happy. You can see a lot of pseudo-phacodonosis. And it was a multi-piece lens which we implanted long time back. So the 3 pieces, when we have a 3-piece lens like this, then what we can do is we can go ahead and fix this 3-piece lens. This is called an ab interno technique. Okay, you don't have to enlarge the incision, you don't have to expand the IOL, you just go inside with small incisions. I create a 0-180 degree scleral flaps, which is a part of the glued IOL technique, and then I bring that lens up and make sure that you remove all the cortex and the capsular remnants, strip off the lens completely, because you don't want that capsule and the cortical remnants to come and occlude the sclerostomy site and where the lens is sitting, the haptic is sitting. Now, of course, you need to do a limited anterior vitrectomy to make sure that there is no vitreous coming in that area, and then catch the tip of the haptic. This is also the basic protocol or the thing which you need to follow in a glued IOL. Catch the tip of the haptic and bring it out, externalize it, and then go in and do the handshake technique, and don't catch the middle of the haptic. If you catch the middle of the haptic, it will break. Catch always the tip of a haptic, and all you can use micro forceps, which is available with Epsilon and many other companies as well, and then create a Gabor Schrödinger tunnel. And once you put that haptic there, then make sure that there is no vitreous there in the anterior chamber as well. And many times you put tricot also and see. Sometimes there can be small fibrils. Put an air bubble, as Dr. Jacob Koshi was telling there, and then glue it. And glue that thing and put glue the scleral flaps, glue the conjunctival flap also. And you can see the post-operative result of this patient. You can see absolutely there is not even a micron of the movement of this. The entire lens is completely fixed. Patient is very happy. The oscillopsia is gone, and the patient's vision also improved to 6/5 in this patient. So again, another patient can see a decentered IOL. When you have a multi-piece lens like this, okay, if you are going to have a PCR, I'm going to put a multi-piece lens, don't leave it in the sulcus. If you leave it in the sulcus, and they can be a decentered. Okay, again this lens got decentered, referred to us by another ophthalmologist. The same protocol, 0-180 degree flap. I'm bringing that lens up through small incisions and stripping that cortex and everything, and externalizing the tip of the haptic, and all with small 26 gauge needle we are doing this. So you can see another patient, you can see this is a 1 month post-op, 3 months post-op. This is again one of our postgraduates. She had a PCR, and you put a lens, and probably the lens, if you put a lens in the sulcus like this, over a period of time that can be decentered, and what happens is you can also produce UGS syndrome. So this is in this case, because it's like this, vertically oriented. I put the 0 180 degree, I was sitting temporarily and put a 0 180 degree vertically. So the versatility of this glued IOL is something which is phenomenal. You can see here, I bring that up all through small incisions, and many times you can use anterior chamber maintainer, or you can use, of course, the viscoelastics we do use very less in glued IOL, or you can use a pars plana infusion if you are comfortable with that area as well. So once you have a PCR, this is a posterior polar cataract. You can see the two typical lines on the posterior capsule. And you put a lens in the, obviously you cannot put a lens in the bag in this with such a huge PC defect. So you put a lens, haptic, the 3-piece lens into the sulcus. What you do is, don't leave it in the sulcus. If you leave it in the sulcus, they can be decentered and can have UGH syndrome as well. So you just lock that lens into the into the bag, into the, into the capsular excess margin. The end point, see, if this is called the locking of the lens. If you have an optic capture of the lens, the end point is the ovalization of the anterior capsule. And this lens will not move a micron. You can see here, 2 months, 9 months, 2 years. And the lens is also very stable, as if the lens is in the bag. And there's no decentration in the long term, there's no UGH syndrome. The patient's eyes are very, very quiet as well. So the patient is also very comfortable. Again, this is another patient, 63-year-old male, drop in the vision, 6 months duration, tennis ball injury. And usually the shuttlecock injuries are the worst. The tennis ball injury comes to the next, and then we have the cricket ball and other things. So this is, you can see, this is a single piece lens. Okay, this is an SA60 lens which we implanted long time back, and now it's got decentered. Obviously, you cannot glue this lens. If it's a multi-piece, we can glue it. We have externalized haptic, but a single piece lens, we cannot glue the lens. What we have to do is, we need to put a suture. So we create an Hoffman's pocket, and go from Hoffman's pocket is something which we don't open the conjunctiva at all. You go from the anterior, from the corneal side back. And you can see here, this is a Hoffman's pocket which I am creating, and then I am creating a side port incision, and then going ahead and putting a suture. The 90 Prolene, or you can use that. One suture goes underneath the haptic, the other sutures goes over the haptic. So it loops the haptic. The suture actually loops the haptic and fixes the haptic to the sclera. So this is one of the methods by which you can fix a single piece lens which is there in the, which is decentered. Again, another patient can see here, this is a hydrophilic lens, something like a Rayner type. This hydrophilic lens, I tried to fix it up. Okay. The problem with this hydrophilic, I didn't even realize that, and this patient was also referred to me during the COVID time. I can see here, this patient had probably an injury and got dislocated. And what I'm trying to do is, I'm trying to fix this lens with the Gore-Tex. You can see that I'm doing an anterior vitrectomy, and I'm trying to fix this lens with the Gore-Tex suture, and I'm putting a scleral groove there. But the problem with these hydrophilic lenses, they are very, very slippery. So don't attempt this, because in this case, see, it's very slippery. I was not able to even fix it up, and the whole lens started going south into the vitreous cavity. Immediately extended the incision and did what is called the anterior assisted levitation of the lens, and brought it up and then put a scleral fixation glued IOL. So quickly I will go through, because this is another patient. You can see here, this is a supraphobe lens. When the supraphobe lens came into the market, they didn't have an injector. So I used the Alcon injector. The message is, don't use one company injector to another for another lens. Suddenly it came into the jerk and produced a PCR. This is an young patient, traumatic cataract, and you can see here they opened up, and the PC opened up, the lens started going into the vitreous. Immediately what I did what is called the AL, anterior assisted levitation. So I go through the side port and bring that lens up, and this is a supraphobe lens. It doesn't have thick haptics like the Alcon SA60. So I just brought the lens up and then went ahead and then put this lens into the sulcus, and the patient is doing well. Again, these are lenses which are dislocated into the vitreous. For example, this patient had a dislocated lens into the vitreous, and you can see here the whole lens is gone in. In these cases, you cannot probably fish out the lenses. You need to go in and do this patient had a nucleus as well as a lens as well. You can see here a hydrophilic lens which is dislocated, a part of the nucleus. So we are in double trouble. We need to remove the nucleus first, followed by the IOL, and then go ahead with the Exnic technique. Again, this patient we can see here, from the same eye, we had the 3 IOLs. Again, this is the patient you can see SA60 lens which got dislocated. For some reason at all, I do not know, probably because of pseudo exfoliation or something which happened. You can see this, I'm using a scleral flap, I'm using Gore-Tex suture. Problem is, over a period of time, this 9-0-proline and 10-0-proline can degrade, and that's why we started using Gore-Tex suture for fixing these lenses. So you can see here, I am trying to fix this lens and passing one suture, one end of the suture in front of the haptic, other one behind the haptic, okay? And you can fix that lens, entire lens. We don't have to explant these lenses. You can fix the entire lens without any problem at all. Again, another patient with a vitreous vitrectomy, nucleus bit removal, and then this patient we had to do an Exnic technique. You can see this is an Exnic technique which has been popularized by the Aravind Eye Care system, and you can see here how beautifully it is being done without any problem. Only thing in the Exnic technique, you need to put a rigid multi-piece lens, and because you need to go through a 26 gauge needle, you need to have a scleral incision and go through that. You can see here, pass a bent 26 gauge needle and loop that haptic into this thing without any problem at all. So only thing is, the main protocol is 0-180 degree and making sure there is no vitreous in the anterior chamber. Again, another patient, you can see here, this is the patient. The video is not working, this one. Why? This video is not working.
I think we're running short of time.
No problem. Okay, thank you very much, KSOS, for this wonderful thing. Please email to me at drmohanrajan@gmail.com. I'll send you a color atlas of the retina and the optic nerve, which will be very useful for you. I am seeking your blessings and support for my AOS elections. Thank you very much. Wonderful opportunity, and the patient attention has